We want to thank the Focused Ultrasound Foundation Symposium for the opportunity to present our work titled The Impact of Optimal Thermal Neuromodulation Parameters on the Efficiency of Focused Ultrasound Treatment. I'm Vibhor Krishna. I'm an associate professor of neurosurgery at University of North Carolina at Chapel Hill. These are my sources for funding, and the ones highlighted in bold are relevant for this talk. Subthreshold testing is often performed during focused ultrasound ablation to treat patients with essential tremor. Ultrasound-induced thermal neuromodulation is thought to underlie this reversible change in clinical effects seen during subthreshold testing. The goal of this testing is to physiologically explore the ventral intermediate nucleus and the surrounding area before a permanent ablation is performed. The most common clinical effect observed are tremor reduction, and at times you also see side effects such as sensory phenomenon or motor weakness. During standard subthreshold testing, 3 to 6 sonications are often performed using low incident power varying between 100 to 200 watts for a sonication duration of 13 to 16 seconds while maintaining temperatures less than 45 degrees centigrade. The challenge associated with this technique is that tremor reduction may not be consistently observed, which may prompt additional sonications or change in target location, which adversely affect the treatment efficiency. We sought to answer two interrelated questions. Number one, what are the optimal thermal parameters for subthreshold testing, specifically optimal thermal dose and optimal spot size? And how does parameter selection for the subthreshold testing impact the overall treatment efficiency? We published this work in Neurosurgery. The thermal maps were downloaded for offline analysis and analyzed using our software. We corrected for any focal shifts associated with thermography acquisition. Thermal dose was then calculated for each sonication, and sonications less than 25 CEM were classified as subthreshold. Corresponding intraoperative tremor assessments were also analyzed. Specifically, we used the written specimens of spirals, straight lines, and writing. Two independent raters rated the tremors with a maximum score of 12 and a minimum score of 0. Statistical analysis was performed using linear models and a leave one out cross-validation analysis to calculate area under the curve. An area under the curve more than or equal to 0.7 was considered statistically significant. We then calculated the optimal cutoff of predicted tremor improvement based on the AUC. We analyzed a total of 331 sonications. The mean thermal shift was 1.3 millimeters. Tremor improved in roughly 24% of subthreshold sonications, with a mean improvement of 22%. The significant predictors of tremor improvement during subthreshold testing were thermal dose, which had an area under the curve of 0.74, and spot size with a similar area under the curve. The optimal thermal dose for tremor improvement was 0.67 CEM, while the optimal spot size for tremor improvement was 2.46 millimeters. These results have direct implications for the technique of subthreshold testing. Currently, the standard techniques involve holding target temperature less than 45 degrees centigrade for sonication durations 13 to 15 seconds. As shown here, these sonication techniques do not deliver the optimal cumulative equivalent dose. We propose to use long duration sonication ranging 30 to 40 seconds for temperatures less than 45 degrees centigrade to deliver the optimal thermal dose for subthreshold testing. When the optimal parameters for subthreshold testing were used, we identified that treatments required significantly less number of sonications. In treatments where optimal parameters for subthreshold testing were used, on an average, 9 sonications were performed, as opposed to 12 sonications for treatments where the standard parameters were used. We also observed 3 concentric rings with varying level of thermal exposure during focused ultrasound treatment. As shown in the MRI on the right side at a superimposed heat map, the central area of the target received ablative dose 240 CEM or more. The mean radius of this target was 2.3 millimeters. Immediately surrounding the ablative zone, there was an area receiving subablative thermal dose with a median radius of 2.2 millimeters. And finally, surrounding the subablative zone, a large area measuring up to 8 millimeter in radius received thermal dose sufficient for thermal neuromodulation. Overall, in this work, we observed that there are optimal parameters that would elicit reliable tremor reduction during subthreshold testing. These include a thermal dose less than 1 CEM and spot size of 2.5 millimeter. We also recommend that long duration sonications be used during subthreshold testing, as the current technique of sonication duration between 13 to 15 seconds for temperatures less than 45 degrees centigrade do not deliver the optimal thermal dose. We observed that using optimal parameters for subthreshold testing improved the treatment efficiency. And finally, we observed that during focused ultrasound, tremor reduction can be a result of combined effect from ablative, subablative, and thermal neuromodulation effects. This underscores the need to identify and define reliable treatment endpoints during focused ultrasound treatment. Thank you.